Good afternoon, everybody. I'd like to introduce you to Richard Hawkey. He's going to be our symposia presenter today, Richard and Chris at the front. And this next session, there's going to be a presentation, approximately 45 minutes, and then discussion. Richard will explain a little bit more. And then you're around till close of play today for any more questions. And I hope you enjoy this next session. Thank you.
Thank you. Thanks very much.
Right. I'm pleased if I start wandering away, you'll just have to make hand signals. I do like to wander a little bit. First of all, before we get into any of the housekeeping or introductions, I do need to sort of make a little bit of a correction. I think it was something that Matthias hinted at this morning around having arranged the good weather. So I've flown in from South Africa, and I would certainly like to take some of the credit for that myself. So let's just start off on the right foot there. Before we do get into the introductions, just to go through the housekeeping a little bit better. As Hannah said, we're going to try and split it sort of roughly half-half, but we've got some leeway there in terms of the presentation. We do want questions, we believe, and when we've done this kind of session before, specifically with what we're talking about, it tends to generate quite a lot of interaction and discussion. So yes, we want to go around and do a roving mic. It's quite an intimate audience, and we want to keep that intimacy and the one-on-one. If there are questions that you have, though, while I'm talking that you think you might forget or you want us to answer and you want to make sure they are answered, there is an email address that you can send them to. The reason we do this is so that specifically we can get back to you with a comprehensive answer if we don't manage to cover it during the session, if for whatever reason we run out of time. And also, we do have the option today to be joined by one of our clinical team, but it's only going to be via telephone and only if we really need it. So that, which is a little bit of a fiddly, it's not the most flowing of mechanisms. So if you do have specific clinical questions that neither Chris nor I can answer, pop them through to the email and we will commit to get back to everybody. Okay. Yes. Sorry, I've just been reminded by Chris, this is not an exercise to gather your data to sell it to a mobile telephone company to repeatedly offer you, ask you if you're happy with your current service provider. It will only be used for this and then destroyed. Okay. To get down to some introductions. So, as Hannah said, my name is Richard Hawkey. I was once referred to by Harvard sociologist Martha Beck as a recovering banker, which I quite liked, so I kind of use that at every opportunity I can get. I used to work in the financial services industry for many years. I wasn't one of the ones that caused the 2008 financial crisis. I don't drive a Porsche. And I had been in the financial services for many, many years, and I went through a burnout and subsequent clinical depression, which was something that I didn't think happened to people like me. Happily married, 2 wonderful children, house in the suburbs, station wagon, all the sort of trappings of success. I was very fortunate in terms of my recovery, in terms of having the right support around me and the right access to the right treatments. And subsequently, I wrote and published a book about my experience. I built some stress management software with several doctors. I went off and got some postgraduate qualifications in applied psychology to try and find out what happened to me. I'd been to several different business schools. I'd been on every single How to Be a Better Leader course in my corporate, and none of this stuff was explained to me. So I thought, well, that just doesn't make very good business sense. So I went off and got a master's through Liverpool in applied psychology, and it was really through all of those experiences and the journey that has ensued that I'm now very passionate about combining technology with psychology and medicine. So understanding how those three combine and combine most effectively. And I think some of the talks we've had this morning have really dovetailed so nicely into some of the things we're going to say. And Lauren, I hope you don't mind. I think you mentioned people using online healthcare as a catalyst for patient power. And I think that's a lovely little expression, and really sums up some of the things that we're trying to achieve. We're also going to be talking a lot about AI. Now, the session we had just before lunch, there are a couple of red flags coming up about AI. Hopefully, we're going to be able to demonstrate to you that what we're doing is applying it in a different mechanism, because we understand some of those risks. A lot of the talks you've had so far today have been about ongoing research. Ours, again, is slightly different. We are in the process of building a technology intervention based on existing research from which we are inferring an outcome. And based on the prototype that we are building, we are going to be putting it through some patient trials to see if we can test the hypothesis of what is inferred in the existing research around behavioral change using technology. So that's kind of really who I am. My colleague sitting down at the front here, he was going to sit over there, but he said he felt like a bit of a carbuncle sitting there by himself, is Chris Knight. He's the director of a healthcare, a digital healthcare agency and digital transformation organization called EGG. And he's been working with me very faithfully for about a year, 18 months, in terms of taking the original concept that I had and helping flesh it out in terms of how this could actually be practically applied in the real world from a user experience perspective, a user design perspective, how this whole thing could hang together. The clinical member of our team, one of the clinical members, we have two, who will be available today for telephone if we need to get hold of him, is Dr. Alexander Finlayson. I do have to refer to his CV, and I shall keep it brief because it does go on a bit. He's a clinical primary care academic at Oxford University and a Department for International Development funded social technology entrepreneur. He has specific expertise in building and supporting digital products in the clinical environment. And he was also awarded the British Medical Journal Junior Doctor of the Year in 2012. I don't know if that's like a sort of a Mr. Happy Legs. I don't know, but so he was. That's who he is. And we've been working very closely on developing a solution that really answers the question that's up on the board. So getting back to the topic of why do we think patient centricity is important in medicine and how can technology help that? And taking it one step further, we actually believe, and this might be a little bit controversial, and we're not doing it to be controversial, but we actually believe that some of the next big things in digital health are actually just getting some of the basics right. And we'll explore a little bit about that. We know, and there's a lot being written about patient-centered health at the moment, and it means different things to different people. It means being able to get the absolutely correct pharmacological makeup to treat a specific condition for a specific person. We also know that in many of the care pathways, evidence-based medicine and patient preference are entrenched. So we know we need to involve the patient in trying to understand what their preferences are around the treatment to improve outcomes. And again, that talks to some of the things that Laura mentioned earlier around concepts like being related and the collaboration between the doctor and the patient. And the reasons we need to be driving patient-centered medicine and improving the outcomes is clearly around symptom amelioration, and then we can't get away from the elephant in the room in terms of the current bottleneck and the supply-demand issue that we've got in healthcare. So to ultimately lower total cost of care as well. And do we think do we think technology can do this? I mean, we do believe so, and we've got a lot of research. You'll see as the presentation goes through, there's a number of references and citations. If you want all of those, please again contact us afterwards. We're happy to furnish all that research. We do believe it can absolutely do this, and we do believe the research shows it. But the one thing I think we need to do is we need to go into understanding how technology can help with our eyes wide open. The development and innovation within any industry and the evolution of that is going to involve some elements of technology for technology's sake, where we can argue the healthcare, the real lived person healthcare benefit, as opposed to the application of the technology because we can do it. This is, I think, this is not a criticism. It's part of a normal evolutionary process, and I think if we just need to go back a few years and look at the first generation of wearable devices. With the greatest respect to some of the colleagues in the room, I know the technology has come a long way since then, but the first generation, we can argue are really more marketing efforts than actually having any significant healthcare benefit. And again, as Professor Mia and Dr. Rich mentioned in the session before lunch, 160,000 apps now. There is widely divergent views around the effectiveness of many of the healthcare apps. There's been quite a number of exposés about random number generators sitting behind some of them. I mean, one of my favorite, and I use the term loosely, but a couple of years ago there was a proliferation of pimple management applications, where the light emitted from your mobile device helped zap pimples, apparently. Clearly that was a load of nonsense. It was rubbish. So the application of technology, we've got to be careful. We have to go into it with our eyes open and understand where that real benefit lies. And we don't believe you can start to talk about patient-centric medicine unless you start to actually look at a slightly broader framework of healthcare, something like the biopsychosocial model. A recent TV program that I saw kind of underlined this, and I'm going to show you a brief clip now. It's a very brief clip, and it's an interview with a man called John Robison, who had lived with autism spectrum disorder his entire life and was administered a fairly new treatment called transcranial magnetic stimulation. And this is really his take on how that intervention impacted his well-being. So I just want to cue that up. Let's watch it, let's hear what he has to say, and then we can discuss it and sort of maybe dig into a little bit more detail about why I say we need to be looking at a broader healthcare paradigm, such as the biopsychosocial model, when we're applying technology. Unfamiliar machine, I do apologize.
That happened to me the first day. I'd say, excuse me, I gotta just step away and calm down.
Is it coming through?
And it was crazy, I thought not seeing emotion was disabling, but seeing it in such tremendous intensity.
You're not getting that.
Was frankly really disabling, and of course, thankfully, it moderated.
But what did you see? Did you have an expectation that there was a world of joy and happiness that you weren't plugging into?
I did, and I was just a crazy fool for that, because anyone who looks at the news knows that the world is not beauty and joy and light. Well, I thought those are the messages I'm missing, and if I could get them, I'd be happy. And instead, the messages were angst and jealousy and fear and worry. And
this is what people around you were exhibiting?
It was a pretty big shock to me. And the thing that was maybe the hardest was seeing people looking at me, sometimes with contempt or derision, and even my memories, for me to remember a time when I was laughing with somebody, and after the enlightenment of the TMS, I realized they were laughing at me, and that made me really, really sad.
This also cost you the relationship at home with your wife.
It cost me my marriage. It cost me clients at work who I felt were didn't like me. And of course, it's a business, right? And should I even care if somebody likes me? But I did. And it cost me friends. And like I said, it cost me even my memories.
You go out of your way in the book to mention that this is the experiences that you had, that even...
I'm not knocking treatments like transcranial magnetic stimulation. I mean, it has been shown to be fairly effective in terms of alleviating some of the negative symptoms of autism. There's quite a few studies out there about it being a viable alternative for things like drug-resistant depression. So I'm not here to knock new developments in technology and how they're applied in healthcare specifically. What I'm trying to bring to the surface is that at the center of every healthcare interaction is a human being with a unique lived experience. And we, as professionals working in the healthcare environment, we really do need to remember that. It is about the human being. You know, there's a terrible expression, and I know this from the banking world, that sort of emanated back in the 80s. You know, it's not personal, it's just business, which is an unfortunate excuse for treating people really, really badly. Whenever you interact with another human being, it's very personal on any level. So for us, there needs to be a consciousness to how technology is applied to understand not only how it impacts specific biomarkers and specific scores on validated assessments, but really how does it impact positively on the lived experience, the well-being experience of the human being? Because we are so, as Monty Python said, you know, we're all individuals. And again, for those of you, I do apologize. This is absolutely probably the worst audience to be now giving a mini lecture on the biopsychosocial model to. But for those of you who might not be fully aware of this, and I do understand there is a spiritual element, a fourth dimension. That's something I'm not quite sure technology is ready for yet. So answering existential questions about life, I really hope technology doesn't ever get to that level that we can do that. But from a biological perspective, George Engel back in the 70s when he first proposed this model, and I need to caveat that by saying first proposed this model in Western academia. Versions of this or this philosophy have been around in other cultures for millennia. Basically, it just says that our human health is a complex interaction between biological, psychological, and social factors that influence and interact with each other. And if we look at things like, you know, the biological aspect, it's the biomechanics and the biochemistry of what we eat, how we exercise, how we sleep, how we break, how we fix those breaks, how we become infected, how we fight those pathogens. Very critically important. I'm a lifelong asthmatic, so I'm really grateful for these kinds of advances in medication because that, you know, absolutely allows me to function. From a psychological perspective, it really deals with how we think and feel about the world, how our thoughts influence our worldview, and how that worldview that we may have and develop influences our disposition and our actions. And a social element, you know, we are influenced by how we were raised. Well, I just went ping. I don't know what that was about. How we were raised, what our cultural and societal norms are, what beliefs we hold dear, what kind of support we have around us. If we take a sort of quite a prosaic example, has anybody here ever had flu? I mean, I don't mean a cold. I mean proper man flu. You know, on the couch for 3 days, can't reach the remote. That kind of flu. How were your emotions when you were lying there, sore of throat and achy of head and groany of body? How did you want to interact with the world? How did those around you help or hinder your recovery? And I apologize, I'm not trying to be sort of banal and oversimplify this, but how we feel physically impacts how we feel emotionally, how we think, and how we interact, and vice versa. That's all we're really trying to say here. And we need to take those various spheres of influence into account, we believe, when we're applying technology. We run the risk of being overly reductionist and missing the points of human well-being if we focus on too many simplified aspects of it. If we look at John's case, the transcranial magnetic stimulation was the biological aspect, so the application of concentrated magnetic waves to specific areas of his brain to stimulate neural activity. From a psychological perspective, we know that it takes time to learn to deal with emotions, to understand the kind of responses that they evoke. When they were all switched on for John in a very short space of time, he was overwhelmed. I think, to paraphrase him, he said he thought living life without the ability to feel the full cupboard of emotions and understand social cues was a disability. But it was only when they were switched on in their full Technicolor surround sound glory that he realized how much of a disability they were, because he had no frame of reference for it. He hadn't experienced it. So from a biological perspective, the transcranial magnetic stimulation did what it said it needed to do. It alleviated those symptoms. But did it improve his life? Not at that point in time. What did that mean for his social aspect? You know, you heard him in the clip. His marriage broke down. You know, his ability to hold relations had now fundamentally changed because of how he interacts with people and how he reads their cues or had been misreading their cues, etc. So again, these things we learn over the course of a lifetime and are continually learning. To have them all just switched on at once and expect to have all those coping mechanisms is unrealistic. So again, I'm not knocking transcranial magnetic stimulation per se, and there may very well be the treatment programs now take a far more holistic view in terms of providing counselling and providing support to the individual and their immediate family members based on experiences like John's. What we're trying to say is that we need to be aware of these things when we look at technology. Sounds quite simple. And paradoxically, we actually think that one of the mechanisms of managing all these multivariate minutiae of the human lived experience is technology, and it is quite paradoxical. And we're not saying it replaces interactions with human beings, but it's really good at monitoring loads of variables and monitoring them infinitely. And there's two things that we think, two specific issues currently in the healthcare spectrum that we think this kind of approach with technology, which we will explain a little bit, can assist with. And the first was alluded to again by Lauren. Sorry, I'm not picking on you, Lauren. It's just so much of what you said led into what I'm doing, so thank you. You know, concordance with evidence-based treatments is low. One of the ways it's being increased is through people educating themselves. So that's one area that we think can help. And another area is around the ability to improve the quality, completeness, and frequency of patient self-report in terms of how they are progressing with their condition and hence how effective their treatment is. The reason for this is again, this was alluded to that, you know, I don't want to get sort of boring about this because, I mean, you can't listen to the news or watch the news a day without there being some headline, some problem, some new white paper coming out, a 5-year forward view. We know that there are issues in healthcare. We've got some fundamental supply-demand issues, and concordance is low. Conservatively, between half and a quarter of people don't stick to their treatments for an extended period of time across a number of conditions. Sometimes percentages roll off the tongue a little bit too easily, so let's take something like hypertension. The 2017 figures in the Quality Outcomes Framework registers across the NHS GP practices for the UK. There were 8 million hypertensive patients registered. Now we know from studies that hypertensive patients sit around the 50% conformity mark. So that's 4 million patients who aren't conforming with their treatment. And when we know things like hypertension is such a precipitating and perpetuating factor in so many other major health incidents, you know, that's a worrying figure. That's 4 million people. Even a minute increase in helping a small percentage of that 4 million improve their concordance has a significant impact and obviously a significant societal benefit. If we take something like major depressive disorder, 4.7 million people registered in the QOF registers last year with major depressive disorder. Again, sits at around the 50% of patients adhere to the treatments, conform to the treatments over a long period of time. So again, you know, we're talking 2.35 million people. These are significant numbers. Fortunately, there's also been a lot of research done as to why people don't conform with their and concord with their treatment plans. And some of it, you know, might seem very obvious, and a lot of these things are quite obvious. So simple forgetfulness, side effects, fear of addiction, poor education around their condition and around their lifestyle and what they can actually do. So poor empowerment, poor patient empowerment. We're going to touch on those issues a little bit later in the form of some case studies to try and make it a little bit more human. The second compounding factor is, or the second issue that we're looking to address is the quality and completeness of patient feedback. Now, it's almost embarrassing to say this out loud, but the more accurate and the more frequent and complete feedback you can give your doctor, specifically for chronic conditions, at a follow-up consultation, the better able they are to adjust treatments for your unique set of circumstances. I mean, that's fairly obvious, and again, there's reams and reams of research that shows this. Why aren't people giving good feedback? You know, I mean, it's in their own interest, isn't it, for goodness sake? So why don't they do it? Again, huge amounts of research has been done into this to try and uncover why. Some simple things like recency error. So you may have had a particularly bad trip to the surgery. You may have heard something distressing on the news. Similarly, something fantastic may have happened to you which had altered your immediate disposition, so you don't necessarily relate some of your symptom progression in its true detail. Other simple reasons why people don't give good feedback are they may just be poor communicators. You know, latent introversion, language confidence, or it may very well be things like cultural and generational norms. My mother, she was born in an era and in an environment where a doctor was the pillar of the local community, incredibly respected, almost revered for their abilities and their knowledge. You didn't question a doctor. Now, I know to this day it causes her great anxiety if she has to report back to a doctor that a course of treatment that she's been on hasn't really worked. In her mind, that's a criticism of the doctor's ability, which we know is not true. You know, we know there isn't one size fits all. We know that there are multivariate complexities, and doctors need the information to get the dosages right, to understand what is the correct treatment program for each individual. But they can only do that if they get the right information. And again, a lot of the information they do get during follow-up consultations, if they're taking biomarkers, if they're filling out assessments, doing a clinical observation, that's at a point in time. It's not longitudinal data, which is, again, it's misleading in terms of how that condition is progressing. We need to be aware of those kinds of cultural and generational nuances if we want to be trying to interact with people in a more human way. Because one of the things that is most likely to disengage people is if you don't connect with them, if you don't identify them as an individual. We'll go into that a little bit more in a bit more detail. The real reason this is something that we're focusing on is because of the current issues in the NHS. The current pressures are well publicised. Last year's NHS figures talk about 2.8 physicians per 1,000 members of the population. It's one of the lowest numbers in Europe. There are some estimates that the UK population is going to be increasing by 8% over the next 6 years. So the supply and demand is going to worsen. And this is not some kind of doomsday prophecy. This is a reality. It's not a criticism. It's just an uncomfortable reality that we face. And what that is driving, it's driving the reduction in terms of consultation time, face time with patients and doctors. I mean, it's one of the reasons things like Babylon is building a case to offer alternative channels to take some of the pressure off of the flesh and blood doctors in the surgeries. I'm not endorsing it and I'm not decrying it, but it's one of the reasons those kinds of technologies are finding airtime, even with all their ethical conundrums. What this means is that, again, these are NHS numbers. They're not my numbers. They're NHS published numbers. The average consultation is now between 8 and 10 minutes. And again, if we had, if we do speak to our colleagues later, they will give you chapter and verse on what their day is like in terms of how many patients they have to see, what they do during their lunch hour, and how long they have to stay after their surgery is finished to finish all the paperwork that they're dealing with. Now that's 8 to 10 minutes to diagnose someone, discuss their condition with them, educate them on treatment options, prescribe a course of treatment that is probably most beneficial to them, and then offer some kind of support in terms of additional resources, some psychosocial support before we sort of hit the buzzer, next patient, please. Again, this is not a criticism. It really isn't a criticism of doctors. One of the issues we're seeing is the ability to fulfill your duty of care as a carer is one of the reasons you get into the caring professions is more out of a sense of purpose and meaning than many other professions. There are easier ways to go and earn a living than becoming a doctor, quite frankly. There's a deeper sense of purpose about why you're doing that job. And when you can't fulfill that sense of meaning and purpose, it causes great dissonance. So a lot of doctors it's unsurprising in terms of the stresses that they are facing and the lack of support that they're getting, that, like the old fable with the cobbler's children who have no shoes, stress levels and burnout levels in the medical profession are some of the highest out there. And these are the people who should know better. But because of the nature of the work they're doing, this is extremely problematic for them. To compound this complexity, comorbidity and multimorbidity is the norm rather than the exception. Guess what? Diseases and conditions don't occur in nice, discrete silos. We've categorized them like that because of our need to understand and reduce a complex model to something that we can understand. So I'm not criticizing the diagnostic model. But what I am saying is that the realities are that more than 3/4 of people who go to a GP consultation present with more than one problem. So there is limited effectiveness really in targeting single illnesses one at a time. I mean, we're doing it and we need to do it, but we also need to find a way of bridging that gap. So we know, for example, some very recent research has put anxiety disorders comorbid with mood disorders more than 70% of the time. So, I mean, that's probably not going to surprise too many people in the room that depression and anxiety pretty much go hand in hand. Similarly, things like diabetes, hypertension, depression, high cholesterol, they live cheek by jowl. So we need to look beyond those single condition silos if we also want to start talking about patient-centric medicine. We can't just be patient-centric about the elements that we pick and choose, because that is not the lived experience of the individual. Okay. Please don't forget, if you have any questions, if you have any strong feelings about what I'm saying, jot them down. Don't lose them. We need to have robust discussions about these things. I believe, and our colleagues believe, that we're approaching a sort of an end of a phase of digital health where a lot of those initial benefits have been taken, a lot of the lessons have been learned, and we're entering a new phase now where these things start to become a reality and become a focus. But I do understand that some of the things I'm saying may be a little bit uncomfortable, maybe a little bit challenging. But again, there are reasons why we're saying this, and we want to engage on it. So please don't forget your questions. really, just to summarize, if we look at the overall problem that we're facing, that we're trying to specifically address in healthcare, it's the initial diagnosis, followed a couple of weeks later or a month, depending on the particular condition and the particular health status of the individual that warrants when they need a follow-up. So that's many tens of thousands of minutes that the individual is then by themselves with varying degrees of support, health literacy, psychosocial capacity to enter into lifestyle behavior changes, etc. So we wonder why some of the medical outcomes aren't as great as we saw in the clinical trials. We propose it's things like this. However, we also believe that, and this might sound a little bit flippant, and I don't mean to be flippant, John Kabat-Zinn, the legendary mindfulness guru, talks about mindfulness being simple. It's just not easy, because you've got to practice it, you've got to do something about it. And we kind of adopt the same approach here. We actually think it's quite simple what needs to be done. It's just not easy. And I'm not trying to be clever with words. And it's precisely this period between the consultations that we think technology is really, really well placed to address in terms of improving clinical outcomes and lowering, ultimately, total cost of care. And we believe that this is simple because there is a host of education, a host of research around when people are engaged, when people are treated and they believe that they are being cared for, they believe that they are being acknowledged as an individual, their participation in their own health improves. And again, this is not me saying it, there are legions of research around this. And again, intuitively, let's put the research and the science aside for a second, and let's even step out of the healthcare setting. You need to buy a new appliance for home. Vacuum cleaner, dishwasher, I don't know, whatever, hairdryer. And you decide you're going to go out on a Saturday morning, because you don't do internet shopping, or you want to touch and feel the product. You don't rely on the online reviews. So you're going to go to a couple of shops and actually do some judgment and purchase an item. Intuitively, just ask yourself, are you more likely to be positively disposed to the shop where the salesperson listens to what you are asking the appliance to do, what your preferences are, what color you want it, how much you want to spend, and then actively tries to meet those needs, as opposed to the one who regurgitates the sales patter and tries to sell you the most expensive one because they get the most commission on it. Now, that's not a completely fair comparison or analogy with healthcare. But intuitively, hopefully, if price point isn't your only consideration, if you have other variables that you're looking at, the person who is actively listening to what you're trying to achieve, and then you believe that they are actively trying to help you solve that, there is a relationship that's formed. We need to remember that we are social creatures first and foremost, and that when we feel we're being cared for and that we are being recognized as an individual, it influences our behaviors. And in healthcare, it just so happens that when we feel like that, it boosts our self-efficacy or our ability to our belief that we can achieve something. And this is such a critical element in terms of healthcare behavior change that maybe I need to explain it with a negative example. So I'll give you the opposite of what self-efficacy is to demonstrate, hopefully, how powerful it is. I've got a very good friend he's also an executive in a large organization. So once a year, as part of their annual risk process, he has to go for an executive medical. And once a year, he's told to stop smoking, to stop drinking every day, to eat more vegetables than what appears on a burger, and to go for a jog. Unfortunately, he he has many of the health risk issues associated with his lifestyle. Now, all that is sound biomedical advice. That is correct. If he does those things, chances are he will feel better, and it will have a positive impact on his quality of life and his longevity. That's absolutely correct. Does he do any of it? No, he doesn't. I'm seeing a couple of heads shaking. Why is that? Is he stupid? Is he thick? Well, he's not. He's actually intellectually, he's quite extraordinary intellectually. But you've essentially just told him to go and climb Ben Nevis in a pair of flip-flops in winter. He doesn't think he can do it, so he won't even try. And in his frame of reference, he is used to succeeding. You know, he's a director in a large organization. You know, he's done well at university. He's got, you know, he's a chartered accountant. He's respected. These are all tags of success. So he's used to doing things that get that kind of output. But he doesn't know how to do the things that his doctors just told him to do. So that makes him very disquiet, and he doesn't even try. There's a theory of behavior change, Lauren, that I was talking about earlier, that talks about 3 specific psychological elements that are needed to bring about sustainable behavior change. And the first is competence, so the ability and skills to do what's being asked of you. In the example that I just gave you of my friend, he doesn't have that. He doesn't believe he can achieve those things. And remember, our beliefs and our perceptions are as powerful as reality for us. So if he doesn't believe he can get the same kind of results that he gets out of merging companies and giving board presentations and working out complicated Excel spreadsheets, he's not comfortable, he doesn't want to do it. The second element in that behavior change framework is autonomy. So the ability to have some decision, some personal decision involved in things that influence you. We know, and this again is quite paradoxical because this is largely how society works, that when we're controlled, either positively or negatively, carrot or stick, there is some element of rebellion and restriction to that. When we have a sense of being involved in something, we have a greater sense of personal agency. Again, in his particular case, that's been taken away from him. He doesn't know how to do that, and he's been told what to do. Now, this may sound really overly simplified, but in a conversation I had with him, one of the reasons, you know, he was told he must go for a jog a couple of times a week. Now, I'm sure the doctor did not mean you can only jog. That is the way he interpreted it. He's uncomfortable going out in public in exercise gear. He revealed this to me. He had been to the shops to try and buy a pair of exercise shorts, and he couldn't find any to fit him. So his autonomy in terms of how must I exercise was not being heard. He was not having any input into it. I mean, he's go home, close the doors, close the curtains, put on some music and dance for 5 minutes. That's exercise. You know, I think, again, we've got too many preconceived ideas about what exercise is, what proper nutrition is, and we tend to swing the pendulum too far. So, okay, you're now going to go from 0 to 10,000 steps in a day. And if you don't do that, you're a failure. Well, that's not what I want to do. That's not what I'm comfortable doing. I would rather do something else. If you allow people to have some autonomy in the decisions around things that affect their lives, you have a far greater chance that they're going to give it a try in the first place and actually then feel the benefits, build that self-efficacy and try something else. The third and final element of the behavior change framework is relatedness. And again, I think, sorry, Lauren, it sounds like I'm really picking on you, but you know, it came out in in your study around the patient experience websites, where people are interacting with other people that they have some sense of relation with. They identify with them in some way or other, and that is hugely powerful. In my friend's example, and then I will stop talking about him, I promise, he's been sort of identified as part of the naughty boys club. You know, it's like a schoolmaster talking down to him. He doesn't want to be part of that club. He's not being related to. He's being spoken at. There's a very different way in terms of how you deliver information to change people's behavior. So the information may very well be correct, but how you deliver it has a huge impact in terms of how it affects and changes people's behavior. So we believe one of the largest addressable failings currently in healthcare is simply how the evidence-based treatments are delivered and how people are empowered to help themselves in a manner that's relevant to them, relevant to their condition profile, and their particular psychosocial circumstances. We're currently building such a system that really is not focusing on the front or back ends of the healthcare value chain. So we're not playing in the diagnostic space like Babylon and many other organizations for very good reasons. I mean, we have evidence-based treatments for a reason, because evidence has shown that they work. So, you know, let's not change that. We've got them. We believe the problem, a large part of the addressable problem, lies in how we deliver them. Are we going to come up with incremental ways to improve those treatments? Absolutely we are. Of course we are. And they will go through the necessary clinical trials, and they will become part of the normal care pathways. But it's how we deliver them to the people. Remember those little 8 to 10 minute consultations and all the time in between. It's at that point in time that we need to be ensuring that the person has competence, autonomy, and relatedness in terms of living and delivering that and adhering to that treatment. We believe that technology has now reached a level of maturity where this is possible with near-language text. And this is where we start to bring up the artificial intelligence element. However, our artificial intelligence application is not around diagnostics. It's not around recommending treatments. It's around simple human interaction in natural language that is culturally nuanced, generationally nuanced, and applicable to the individual, so that we can elicit feedback from the individual in a way that is far more normal than repeatedly responding to a fairly impersonal Likert scale rating on their symptoms, for example. Not saying they're not useful. It's one of the reasons why apps, you know, lose their appeal after a certain amount of time. They become stale very quickly. The artificial intelligence, it's reached a level now where we can continue and we can learn with the interactions and conversations, and we can respond as those conversations change. We know that simple text messaging services that remind people to take their medications, they're effective. Again, there's a whole host of research that supports that. Similarly, there is a lot of growing research into some of these chatbots that show they improve and increase engagement. But I'm hoping that up to this point in the presentation, I've also made it clear enough that whole person health is more than just taking some medications for one condition. We need to be providing mechanisms that support multiple aspects of a treatment regimen across multiple conditions in a way that is psychosocially relevant to the individual, delivers tangible well-being benefit, and, I know, the list goes on and on and on. It's like Utopia I'm describing here. Doesn't increase costs or task burden to the overworked healthcare professionals. So I know that's quite a big claim. It's a very big claim. It's ambitious. But it needs to be ambitious because technology has got to a stage where we actually need to be doing better than what we're doing right now to help people. It has the ability to. Much technology has just been applied in the commercial world first, where you can make a buck quickly. Technology interventions into healthcare are about, I would say, 5 to 7 years behind the rest of the other industries. So we need to be catching up. Because a lot of the stuff I'm talking about, the personalization across multivariate environments, is being done in other industries already. It's why you're being targeted with such appalling spam and nonsense all the time. So they're already doing this in other industries. We need to start doing it in healthcare, and we believe we can. So, as I said earlier, this is ultimately at the center of everything we're talking about, and everybody in this room, it's about the human being, and it's about improving that unique lived experience for them. I do realize that a lot of what I've spoken about now is a little bit antiseptic and possibly a bit dry. The science is important, and we believe in the science and we're applying the science, but perhaps another way of demonstrating the concepts that we're talking about, that we are now taking into production, are using some case studies of some real individuals to show what their unique issues are and how this kind of concept could assist them. I'm going to have to do my little fiddly with the YouTube again, because I need to bring up another brief video clip. So this video clip is about 2-time Olympian and extreme athlete extraordinaire, James Cracknell, talking about his experience, him and his wife, Beverly Turner, talking about their experiences when he was discharged from hospital. I don't know if some of you know, but about 8 years ago, he experienced a traumatic brain injury during one of his epic endeavors. He was attempting to run, bicycle, and swim across the United States. And early one morning, he was up doing a cycling leg. And I don't know if you know, you've seen the American trucks, those big American semi-rigs, and they've got those mirrors that come out on these stalks because they're so huge, these trucks, so the mirrors need to be quite far out so they can see what's behind them. One of those trucks overtook him, but it overtook him a little bit too close, and the mirror hit him on the back of the head at 70 miles an hour. He was wearing a helmet, but that's how he sustained his injury. And this particular interview on Sky was talking about their overall experience, but this particular excerpt really talks about something that they thought they had got right in terms of the entire treatment and rehabilitation process, which was, taking his medication every day. It doesn't sound too difficult to do, hey?
Makes you much more resourceful and resilient.
Yeah, so the one thing I'll say is when you're at school and you think, I go back in time and think, I wish I'd asked that, because even though it seems like a stupid question, there'll be loads of other people who go, oh, thank God you asked that. And when I left hospital, you get given medication you've got to take every day, and I probably wasn't good enough at questioning, right, what specifically to be taken when. And so I ended up making sure I took it every day, but I thought I'd take it in the morning so I don't forget. But then I was taking my sleeping pills in the morning, which then meant I was quite asleep for the rest of the day, which then means that you actually
but that was bad. That was bad. After accident care.
It's not my fault.
It wasn't your fault. They'd explained to James that the medication that he should take, but he was clearly in no fit state to understand the medication he could take because he was off with the fairies. And so that was, for me, that was another example of just poor aftercare from the accident, of not really equipping us as a family to deal with what he was going through. Okay, that's your experience then?
Well, I think
firsthand what it's like to live with a brain.
Apologies. So again, I really do need to highlight this. These clips are not intended as criticisms. Okay, it's nobody goes out of their way to deliberately deliver confusing advice. Through a whole host of circumstances, this happened to this person. Through other interviews I've seen, it took several months before this was uncovered. Several months. And the reason was because they were actually trying to understand why his rehabilitation was progressing so slowly. It was because he was off asleep. I mean, we could, it's comical in a way, but technology, that shouldn't happen. And obviously there are medication reminders that could have handled this, absolutely. But imagine if there was a way that through a conversation, possibly not even James at that point in time, because as his wife pointed out, he was away with the fairies. She probably needed the support. She probably needed the education around how to administer the medications, what was his progression like, and what did that potentially mean for whether he was taking the medications correctly or not. That could have probably been brought out a lot sooner at a follow-up consultation if those kinds of conversations are then reduced to a symptom progression, a side effects progression, etc. Another incidence where this, the ability to empower the carer is incredibly important, was to do with my late father-in-law. He had Parkinson's, and he had also suffered a stroke several years previously. In where we live in South Africa, not all doctors have electronic medical records, and where there are electronic medical records, they are most certainly not integrated. So there is no single view of a patient. My father-in-law was admitted on a Friday night with pneumonia. He was fairly delirious, so he certainly couldn't communicate. And the doctors he usually deals with weren't actually available on a Friday night. Fortunately, my mother-in-law previously had the foresight to take his medication and stick each tablet onto a piece of paper and write next to it what it is and at what time that needs to be taken. Now I ask you with tears in my eyes, in the 21st century, can we not do better than this? And it's those little things, because those are the realities of someone's life and of the person who's caring for them. Walking around in her handbag with a piece of paper with pills stuck to it with sellotape. That's how she manages things. It's effective, but we've got to be able to do better than that. Unfortunately, it's come to the point where I have to talk about myself. Three things. I shall not let this become an American TV reality show. My experiences that I'm going to talk about did not happen in the UK. Okay, so we're not talking about the NHS here. However, subsequently 2,000 hours, more than 2,000 hours as a telephonic counsellor, postgraduate studies in applied psychology, and many, many hours spent with various clinicians devising the concept of the system that we're building, have shown that I'm actually quite average, that my experiences are quite common. So I'm not as unique as I thought I was. As I mentioned at the beginning of the talk, I was a highly functional individual within the corporate world, quite grumpy and cynical, but functional. I was achieving a lot of things. I was doing all the right stuff. Type A personality, controlling, perfectionist, time urgent. There may be one or two of you in the room. Let me see, I can see smiling Riley. I'd imagine there'll be quite a few of you in the room. And that's not necessarily a bad thing. We get stuff done. The unfortunate thing is we often get stuff done at the cost of ourselves and at the cost of others. So I went from being highly functioning to not being able to get out of bed within the space of a week. I experienced the volcanic nausea and paradoxical anxiety that go along with some antidepressant medication. If my wife and I had potentially been educated and reassured more appropriately, we may not have been so immediately panic-stricken about my obvious decline into disability overnight. So when we can inoculate people against an issue, and in my case, we understand that these kinds of side effects are quite common. They tend to moderate over a few days, but if they don't, there are a host of other treatments available. You know, that's all you have to language. It doesn't make experiencing the nausea or the paradoxical anxiety where you go from being functional and grumpy to being terrified of a dust mote in a shaft of light. It doesn't make it any more pleasant, but in terms of that immediate management of the condition, it puts it in a frame of context that says, okay, well, this is known about, it's not just some weird reaction. It usually passes, and if it doesn't, we can do something about it. Similarly, it's also quite useful to understand the effectiveness of treatments that one's put on. Up until that point in my life, my frame of reference for getting ill was feel ill, moan about it to my wife a lot, go to the doctor, be prescribed something, feel better in 2 to 4 days. You know, that's kind of how it worked. Or headache, paracetamol 20 minutes later, you know. That's what I understand about illness. I certainly didn't know that antidepressant medication can take many, many weeks to reach therapeutic effect. So again, just empowering people with that education and potentially not at the point of diagnosis. Handing them a fistful of brochures may not be the best time to give them that education. Perhaps the best time to give them that education is when they are reporting on those side effects. And then you can reassure and offer education at a point in time that suits them. So you retain their autonomy in it. The last one I want to briefly touch on, again, is my mother, Shame. I did ask her if it was okay if I spoke about her twice, and she was okay. She even packed me a lunch today. She has late onset diabetes. She was diagnosed about 20 years ago. And she's been incredibly inspirational in terms of how she's managed it through her diet and through exercise. But over the last couple of years, she's felt increasingly lethargic and just hasn't felt as good. So at one of her checkups, she mentioned it, and they said, look, okay, the time has come that the oral assistance is no longer good enough. You now need to start actually injecting insulin. Come back next month, and we'll show you how to inject yourself, and we'll give you the insulin. That was a very dark month for my mother because she believed that she had failed in managing her condition. Now, I mean, many of you know, to manage your diabetes for 20 years she'd done a very, very good job. And this was actually just a natural, normal progression of the illness combined with the natural processes of her aging. It's absolutely nothing to do. She hadn't done anything wrong, but she didn't know that. Also, in her frame of reference, an injection means a syringe with a plunger, fiddling with needles, taking them out of packets, putting them on, sticking it. That is what she understands by an injection, which is clearly not the way insulin is administered chronically. So again, the ability to provide the right kind of education that's demographically relevant to her, at her age, for her conditions, at a time and place that's relevant to her, we believe has the ability to help in terms of not only managing those anxieties, because unfortunately, and again, ironically, the anxiety she felt made her diabetes symptoms worse, which is not unsurprising. But you actually empower the individual to take greater control of it. And because ultimately it's all about the minutes in between the consultations. Chronic care is about those many, many tens of thousands of minutes when we're not with medical professionals. And I think in summary, before we get on to the questions, it's probably fitting to just give a quote from one of the doctors on our clinical team who says, devolving the pathway between what we know and what we do represents a powerful opportunity to improve outcomes for patients and efficiency for doctors. As a doctor himself, he experiences great anxiety at the end of the day when he has been unable to do everything that he knows has been written, said about a particular condition, because he's got 8 to 10 minutes to do it. Or he may just, it's impossible to remember all those things at that point in time. So, have we got any questions? Have we got any questions come in, Chris? Do we need to move towards the microphone? I have no idea what that did. Does anybody have any question? We do have some. Yes, ma'am.
Hi, I'm Simone from Research and Enterprise. Thank you very much. It was absolutely eyes-opening, and it's great to hear people that think about this holistic treatment the way it really should be applied. But I think I have a provocation, because you've been talking so well about the fact that we need to connect the psychological and the social factors to the actual technology. But then the funding and the research is always focusing on the actual technology. How do we put back the effort into training the people that are actually working with the technology, that are actually working with the patient? It's not about the quantity or the number of minutes of the interaction, but it's the quality. And this is something that the government doesn't fund. We don't fund education, we don't fund training in psychological attitude.
So,
I'm not hoping for you to have the question, it's just
no,
provoke further discussion. Thank you.
No, thank you. I think it's a very good question, and I would like to respond in terms of my own observations. I'm very envious of the UK right now, because I believe there is a trifecta of support for psychological awareness right now. There is political will to raise the profile and raise awareness around, unfortunately it's always framed around mental health, and mental health is always a negative, whereas every one of us in this room has mental health. You know, sometimes it's good, sometimes it's bad, sometimes it's, you know, clinically needs attention, sometimes we float up and down on a variable scale. But there is raised awareness coming from the government. There is, we can argue that this is a good thing or a bad thing, but there is certainly celebrity and public support about it. And there are enough, and this is the bit that you have to forgive me for not choking on. The economists have written the white papers. The numbers have been done. So there is a financial reality around doing something different. How long that takes to translate into reality, I don't know. What I do know is that, certainly looking as an outsider looking in, I'm seeing extraordinary things happening in the UK society in terms of this. How that gets down to individual doctors and carers in general, I think is also, I think we've got to be careful of just putting it at the door of the government. I think it's also incumbent upon all of us in terms of raising our own self-awareness that our health status is an intricate link between our physiological symptoms and our psychological symptoms, and we need to be able to do a scan that not only worries about whether we're coughing and got a headache, but what is the content of our thoughts? How negative and cynical are we? What kind of emotions are we experiencing? And as we raise our own self-awareness and we raise that around us, it's almost like the ripples in a pond. If we throw it in, those ripples spread, and I'm certainly seeing that. And for me, one of the things that is extraordinarily powerful is the two doctors that we're working with. They're young doctors, they're in their 30s. They get this stuff. It was within the first 10 minutes of me speaking with them about this concept. I mean, who am I? I'm not a doctor. I'm from, the dark continent. How on earth would I know anything? They said, yep, no, that's it. That's absolutely right. That's what we want to do. So for me, that is hugely positive that there is an awareness of this. And I think there is I'm certainly seeing an increasing amount of research coming out now around supporting this. and hard evidence-based research that says, when we take a broader view, and patient-centricity, the current approach that we've got about trying to incorporate patients' preferences in treatments is but an element of that. Sure, it's only one element, but it's there, it's starting. And I think it's going to grow because the results will drive it. I think the results will drive it. Yes, sir.
So you talked a lot about a biopsychosocial model, which is great, and totally buy into that. I think I might be slightly controversial again, because I think the last 10 years has seen an enormous advancement in psychological therapies in this country, whether it's GPs being trained on motivational interviewing, whether it's nice guidelines on CBT for pain. I'm a physiotherapist by background. Probably about 60% of my colleagues now don't even touch or examine a patient. They just talk to them and go on psychological markers. And they'll get some very good results, which is fine. But my concern is, if we do believe in a biopsychosocial model, maybe even a spiritual side as well, that is integrated, where does the integration happen? Because what I've heard in the last 20 minutes of your presentation, which has been great, has purely been psychological.
Okay, so I think the psychological component really comes down to the how. Because we're not interested in changing the diagnostics or the treatments. The treatments are being done, be they biological, be they psychological, CBT. So we're not looking to deliver psychological treatments. We are looking to support and be a companion for patients along their journey, but a companion in a way that is more interacting with them in a far more natural text manner than a host of apps where you have to go in and record things in a very sort of clinical fashion. So that's the elements that we're trying to incorporate. So we're not saying that we want to change any of the biomedical treatments. We don't want to change any of the psychological. There's plenty of people out there delivering CBT elements, and again, I mean, I've got my own personal views around how effective and some of the risks associated with delivering things like CBT via different technological means. Ours really is about the connection and extending that therapeutic alliance between a patient and a doctor, and allowing that patient to feel more cared for so that they are empowered and activated to take a greater interest in their own well-being and to manage their own healthcare better.
Say one other thing, sorry.
Please.
I will hand over the microphone in a moment. I mean, in many ways, it sounds like you're looking to then master the social side of it and create a wider network of people. Because, for example, the first example you gave with James Cracknell, it doesn't seem that he'd be in any capable shape, whether it's physically or mentally, to actually understand what someone was saying to him. I think those are his words. Even if he was getting prompts all the time. So maybe the real sweet spot for this sort of approach is actually with the carers and ensuring that the carers and the primary carers, the significant others, etc., are not the patients of tomorrow. And that's where the primary advancement will be with that biopsycho and social model.
Absolutely. I mean, we do see empowering the carers. A treatment. Many conditions don't just affect the individual, they affect the entire family and wider community. So yes, taking things like confidentiality and privacy issues and all those good things into account and the ethics associated with that. Clearly you can't make someone's treatment regimen known to all and sundry, but absolutely where there are cases of James Cracknell, his wife, she at that point in time needed to know what to do. In my own personal circumstances, my wife was left to pick up the pieces. She was the one who had to go and do all the research, find out what was going on. She was the one at that point in time who needed to be empowered, quite correctly. At a later point in time, I was capable of taking over things. At that point in time, I wasn't. And it's absolutely those kinds of things that we are looking at in terms of empowering the right people within that social grouping at that point in time to greatest effect. Yes, sir.
Some of the most powerful messages you've given us are based on personal experiences and case studies.
Yes.
Family case studies. One thing I think you didn't mention, although it was evident in the James Cracknell case, was the role of the patient advocacy groups. Now, James was supported by Headway, which
Yes.
you know is an
Yes.
organisation that supports people with head injuries. And I think one of the things that they are very good at is supporting people in, we've been through this process, this is what you're going to expect. So you've got the diabetes groups, you've got the Parkinson's groups,
Asthma.
you've got the head
Yep.
injury group.
Yep.
So what do you see the role of these individuals in the process of recuperation and recovering from head injuries?
So it's certainly not about replacing or re-engineering the wheel. So one of the things we are very conscious of is the ability to support people and manage treatments and elements of treatments across conditions. Because it's just too oversimplified to assume that someone just has diabetes and just has hypertension. And having multiple apps and management systems for that is just not sustainable and practicable. However, where there are deep centered areas of technical and condition support that are well supported and peer reviewed and all those good things, absolutely an affiliation with them. Now, would something like Headway, I mean, Headway in terms of a traumatic brain injury is possibly maybe not the best example, because a traumatic brain injury is quite a focused event, although it may manifest in many different symptoms down the line. But for example, there are depression groups, there are bipolar groups, there are diabetes groups, do we want to just devolve that management to one particular group, and the dominant condition, and what is the dominant condition? So absolutely, the work that those people do is invaluable. I belong to a group in South Africa, so I understand the value. I would not want that replaced. But there are day-to-day interactions that you might want to have at a time and a place that is convenient to you, as opposed to at the next meeting or having to phone a specific individual within that group for the support that you're looking for at that point in time. So it's not about replacing them. It would be about augmenting that on a daily basis.
Having had experience with Headway, I think what you're saying is absolutely right, and I think there's a blended approach. And I think self-advocacy groups like Headway can actually create self-fulfilling prophecies. So each person is an individual, and so with especially with an acquired brain injury or something like that, one size doesn't fit all.
Right.
So what happened to James Cracknell, if it happened to somebody else, may not have the same outcomes.
Yeah, absolutely.
And so it's about, those groups are really important, but they have to be tailored for an individual. Otherwise, Headway can come along and say, right, you've had that injury, that's your pathway, that's what you're going to end up. And it takes away the individual, and it's about the individual and individualised care. That's really important, and those groups can only provide a support that has to be tailored for an individual.
Thank you. And I also, but I don't think it's a bad place to start in terms of the treatment pathways as they exist. So, for example, a particular type, if this is a particular type of treatment pathway we have for this particular type of traumatic brain injury, as a starting place, there's nothing wrong with that. What I'm saying is the ability to interact with that person far more frequently and in more detail is going to allow you to tailor it to an individual approach far quicker. So yes, I mean the blended approach, absolutely, that's the right term. Thank you.
Thank you for your talk, and thank you for highlighting how the rational framework of providing information does not equal understanding the meanings that people take to the general practitioner. So I was just take 2 points. One, you said that we do not have to increase the task overload of general practitioner and physicians. And as our colleague said previously, the government unfortunately doesn't found quality care and quality improvement. So I was wondering if you could provide us, from your personal experience, some suggestions on how to increase and promote change for practitioners themselves, and how to better care for them.
Okay. This is a very personal view from interacting with practitioners. In terms of their own personal care, I think it would probably be quite a good approach, again maybe slightly controversial, but to have some kind of supervision. And I don't mean supervision in the traditional sense of being overseen, but almost a debriefing that needs to happen in a non-formalized way, but that is slightly formalized, so that there are the kinds of support systems that are out there. There needs to be the education around the individual. Again, I know a lot of this is actually happening for some of the doctors in terms of understanding when they're feeling burnt out, when they're feeling disillusioned, what they can go and do, and the avenues that they can go and talk to people about it. I also understand that there are many rites of passage within the medical profession, as in many other professions. So it's still, unfortunately, quite normal to, pull a 24-hour shift in A&E as part of your training, which, when you understand what lack of sleep does to you, I mean, it's just madness. How that gets past health and safety is beyond me. I can't understand how that can happen at all. So I think we can't underestimate the cultural aspects of what has gone before in the medical profession, and part of it is about working really hard. Part of it is the realities of the situation they're facing. Now, again, speaking with the doctors that we're working with, they're deeply, deeply concerned about the number and the makeup of GPs, because fewer and fewer GPs are entering and staying in general practice. A lot of the young GPs, and this is not a scientific, this is a colloquial, anecdotal evidence they have from their group, aren't working 5 days a week because they just can't. And a lot of the older GPs are going to be retiring. So what can they do to benefit themselves? What can we do to improve the lot of the GP? Yes, I know there are programs in terms of actually actively monitoring and assessing and addressing stress within practice staff. It's part of the general practice 5-year forward view. So there is money that has been allocated to those kinds of programs. How those are being implemented, I don't know. At the end of the day, I'm a card-carrying member of the Pragmatist Club. I love research. I think it's fantastic. But unless you can take that research and implement it in a way that makes tangible benefits in people's lives, I don't think you realize the value. So it's acknowledged as a problem, which is the first step. It's been acknowledged at the highest levels that it's a problem, and money and effort is being put towards it. Is it the right money and effort? I don't know. I don't know. Sorry, that feels like a very unsatisfactory answer. I would love to say yes, and there's the 5-point plan that's being followed, and it is going to work. At the end of the day, doctors are individuals as well, with their own makeup and history and experience. And not all GP practices are experiencing the same levels of stress and overwork. But thank you for asking and caring. Anybody else? Or are we going to tea early?
I think we should probably go for tea early, but one possibility is that we have a juxtaposition between a medical profession that delivers in a pathogenic way. Yeah. They cure and they prevent. Yeah. But actually, salutogenic approach might be slightly better. Yeah. How can we be a bit better, a bit more often in everything we do? And until we have a mind shift from a pathogenic society to a salutogenic society, I'm afraid we'll be sort of just stomping through treacle and getting nowhere.
Sure. I mean,
But that's where the societal piece comes in, because maybe we shouldn't just think about a sector, i.e. medical, or a condition as in this, but actual societal benefit and crossing many different boundaries and bridges.
Very good point, thank you. Very valuable comment. Thank you. If anybody has any other questions that they don't want to ask now, please. Oh, I'll put the email address up again. Please send them to us. We will commit to get back to you. If there are any deep burning clinical issues about the whys, wherefores and risks and ethics and those kinds of things, please send those as well. All right, thank you so much. I know this was a hard session, hour and a half after lunch. In South Africa, we call that the wildebeest session. Because if you've ever seen wildebeest in the wild or on Discovery, they kind of do that a lot. They nod their heads. And so I do understand that after lunch, it's quite easy to nod off. So thank you for your attention. And thank you for your participation. And thank you for being involved in healthcare and giving a damn. Great. Thank you.